Okay, good morning, everyone. Welcome to EMCC. We will call the meeting to order. So just a couple housekeeping items. For those of you on the Zoom, thank you for joining. And if you're not speaking, if you would mute yourself, that would be much appreciated. We will, go back and forth from the room to the Zoom so that everybody has the opportunity to speak as we move through the meeting. So let's start with introductions. And so let's start with the members on Zoom. If we can start with introductions, that would be great. And before we do that, I do want to introduce a new member to our committee who's a citizen rep from South County. And her name is Luz Garcia. So when she introduces herself, Luz, you can tell us a little bit about yourself and welcome to EMCC.
It's a pleasure to be here joining you guys this morning. My name is Luz Garcia. I'm a PA. I've been a PA for 14 years now, and I have worked in Soledad, Salinas, have worked for Clínica de Salud, Soledad Medical Clinic, and currently in Gonzales Medical Center here in Gonzales, providing the medical care to our ag workers and Spanish-speaking community. And thanks for invite.
Thank you.
Harry Robbins, Citizens Rep, and Luz, welcome to the committee. I'm glad to see that filled. You're stepping in some very big shoes with Harold as your predecessor, and welcome.
Jody Schaefer, Citizen Rep as well, and I really look forward to working with you as well, Luz. Welcome.
Tina Nieto, Law Rep. Luz, welcome.
John Anthony, Monterey County.
Okay, go ahead.
All right, thanks, Cheryl. John Anthony, County Park Ranger Supervisor with Monterey County Parks, also part of Public Works, Facilities and Parks.
And
Nick
Cheryl
Greenson,
Fire Chief, Mid-Coast Fire. Too hard.
Nick Greenson, Emergency Physician, Salinas Valley Memorial.
Gary Malay, OES.
Susan Blitch from County Counsel's Office.
Roxanne Super EMS Agency.
Mike Hesslinger is here as the alternate for American Medical Response. Hi, everybody.
And Sharon Henry here with AMR, Chief Operating Officer, AMR West.
Michael Arquidis, representing Advanced Life Support Fire Service.
Leanne Magoski, Emergency Communications Director.
Tino Oriano, AMR Operations, primary EMS provider.
Okay, thanks everyone on the Zoom, and we'll move to the room.
Sam Ballesteri, retired EMT.
Steve Brooks, EMS Agency Staff. John Burley, EMS Agency Medical Director.
Carla Spencer, Hospital Administration and the Chair of EMCC.
Teresa Rios, EMS Director.
Deputy Andrea, EMS Agency.
Deborah Hopgood, EMS Agency.
Kimberly Hernandez, EMS Agency.
Okay, thank you all. Again, welcome. We'll move to item 2, public comment. Any member of the public may address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda. The EMCC will listen to all communications but may not take any action. Does anyone have any public comment? Dr. Red Close, I see. Do you have a comment?
Yes, I do. Can you hear me?
We can. Thank you.
Oh, perfect. Thank you so much. Yeah, I will. I very much appreciate the opportunity to address the group. Teresa and I have been working on a couple of projects that I wanted to bring up to the group because obviously I think this team is very well aware of the overdose, fatal and non-fatal overdoses that are increasing so dramatically in Monterey County and then as well across the nation. There are a couple of different manners that we are hoping that we can work in collaboration to address this increase in overdose. One of those is with the program OD Maps, and I know that was brought to EMCC actually shortly before COVID came to Monterey County. And that is basically a tracking system that is of no charge. What it does, it allows us to know where overdoses are happening and what is in our street supply, so we can then try to do an outreach into the community, either with naloxone or with SUD service information, medication safety information, basically so we can get a rapid and thorough response to try to help the patients, their family members, and everyone in need in the community. There are a number of different ways that OD Maps can be used. One of them involves full integration with ESO, but others are truly available basically now, where on scene, someone could input the information or we could do some data uploads. And so what I would like to offer and request of the committee is that we consider how we can start using that, because I think we're all aware that our mental health crisis and substance use crises are going to worsen as we come out of our COVID immediate response, and we're going to see a lot of trouble in our community. And I think this is one way we can try to address it. A second thing I would like to bring up is Naloxone, the Leave Behind program. I'm sorry, I'm not on video. I haven't figured out what's up with my screen right now, but we have Narcan nasal spray. It's a free, no cost to any agency program. The policies and procedures are written by our EMS agency, and you can leave behind. Oh, hi. There, now I'm back. Wow.
There you are. Okay.
Sorry. But you can do Leave Behind Naloxone. We have information on how to administer, even some of the kits we've been putting in little mask protectors. We have SUD service information. Basically, you can give that literally at the time of an overdose to the patient, the family member, anybody on scene that you think would benefit from this life-saving drug. So what I would like to do is propose that we revisit these two issues in a community response to our increased overdose and what we expect is going to even worsen. So thank you. That's my 3 minutes.
Rev, I have one question for you. This is Harry. We had a presentation by a doctor, and I've forgotten his name. He's a neighbor of mine just up the hill from CHOP, who brought this to our attention about, I'm going to say about 6 months ago. When we consider that, would it be wise to have him present as well? And how does what you're recommending mesh with what the doctor gave us?
I presume you're referencing Dr. Casey Grover?
Precisely.
Yes.
Exactly.
Yeah. For anyone who doesn't know, Casey and I are actually married, and we work on all of this together. So happy to pull him into it. He's on another meeting right now, or he would be in attendance with me today.
Okay. Yep. I'm your neighbor from down the street, and I forgot the name.
Hey, Greg's your neighbor too, Harry, just if you're wondering. So
yeah.
Okay.
Thank you. But very much so. Yes, please. We're all in this together.
Okay, fantastic. I just want to make sure we're in sync on that.
Yes, 100%. Any other questions? And I thank you for the time to be able to bring this up to this crew.
So hi Rev, it's Jody. I'm assuming that when we get to the end of our meeting, we can put something on an agenda for you so that we can move forward with this, since this is just public comment.
Yes, I would very much appreciate that. Please reach out to me directly, and I am happy to help in every way.
Jody, can we put that forward under go to the order?
Yes.
Okay.
So that was going to be my suggestion, that we'll definitely take a motion to add it to a future agenda. And thank you, Rev, and Casey, I know you're not there. However, we would love to have you back next time, and we can talk a little bit more in depth and get it on our future agenda. But so very much appreciate you being here.
Thank you. I appreciate the opportunity to get to speak with the committee. I much appreciate it. Thank you, everyone.
Thank you. Okay, any other public comment? Okay, we will move to item 3, approval of our January EMCC meeting minutes. And
Madam
we'll-
Chair,
I move approval with one question.
Okay. Wait, did I miss something?
yeah, before there is a correction to the minutes, if I may.
Okay. Oh, okay.
We did not record Leanne Magaski's attendance at the last meeting, so that needs to be corrected on our minutes.
Okay.
So I'll second approval, but I guess I need to know what Harry's question is.
My question relates to the item on page 6. Sam Ballesteri asked a question on the percentage of first responders that have been vaccinated. I don't think we got an answer to that. Will an answer be forthcoming today?
I'll address that when I do my.
Okay. He's giving out.
Harry, Jeff DeAndrea will address that when he does his report.
Very well. I recommend approval.
Okay, thank you, Harry. And the second was?
By me.
Oh, Jody, okay.
So the motion needs to include the correction.
And so the motion is to include the correction of Leanne Magaski being added to the present roster.
Yes.
Okay. And Jody, second. Then we have to go, we do roll call, right? Okay, let's do a roll call vote on the Zoom. Let's start there.
So my recommendation is that we actually ask them as opposed to just having them talk over each other.
Okay.
And I'd be happy to do that if you wish.
Okay, go ahead, Steve.
All right, so for the roll call, Harry, I know you made the motion. You vote? Aye.
Aye.
Jody Schaefer?
Aye.
Tina Nieto?
Aye.
John Anthony?
John Anthony abstains. I was absent at the last meeting.
Thank you. Cheryl Getz?
Aye.
Nick Greenson?
Aye.
Michael Arquides?
Aye.
Tino Ariano?
Aye.
And Carla Spencer?
Aye.
Did I miss anybody? Thank you.
Okay, thank you, Steve.
Paul Wood? Paul Wood, thank you. And how do you vote, sir?
Aye.
Thank you.
Hey, Steve, this is Jim Langborg. I had a hard time getting on, so I don't know if Cheryl is acting on my behalf, but yeah, after 12 minutes of trying, I got on.
Thank
I
you.
vote in the affirmative.
Thank you.
Thank you. Okay, I think we got everyone. We'll move down to item 4. So item A and B, there are draft meeting minutes for the MAC committee and operations subcommittee for your review. And we'll move to item C for an update from Ms. Teresa Rios on the EMS agency.
Thank you. The first thing I want to report is that very sadly, Laura Wallen, our health program coordinator, has decided to leave the EMS agency. Her last day is Tuesday, March 16. The EMS agency recognizes Laura's significant contributions to the clinical and specialty care programs in the county. She has always showed commitment to ensuring the success of our programs and the best possible care for the residents and visitors of Monterey County. We are definitely going to miss Laura, but we wish her the best in anything that she does. We are in the process of working to create and implement a transition plan for Laura's areas of responsibility. An email with that transition plan will follow in the next week or so. In the meantime, please feel free to reach out to Deborah Hopgood, one of our new EMS analysts, for any questions or concerns related to the specialty care programs. Next, I want to follow up on what Dr. Close said. Dr. Close from First Christ reached out to the EMS agency with a request. she would like to be able for her program the program OD maps to connect directly to the ESO Solutions countywide data system to extract overdose related data so she can have the data real time. We are currently providing data to her on a monthly basis. It's just aggregate data. But she would like to be able to do that directly. From what she told us, this is something that is already happening in other jurisdictions. Not every jurisdiction has a system like ours where there's an umbrella account with each entity still having their own account with ESO. So we are looking a little bit more into that. So whether we are able to move forward with doing that kind of connection requires more looking into on our part. We don't know if that requires an MOU to the existing ESO agreement, or if it's something that would be an individual, some type of individual agreement between Prescribe Safe and each of the entities, the local entities. As a first step, we invited her to come and speak at each of our 3 committees. I also brought this up at the Monterey County Fire Chiefs Association. There seemed to be support for the idea of that direct connection, but more information to come. I think that we need a little bit more detail as to how that would work, and then what happens when we start looking at amendments to contracts, new MOUs. Those can be not very easy to process, especially when we are talking about pretty much every entity in the county, the ones that are participating in the ESO. I also want to report that the EMS agency received a request from AMR to add a temporary surcharge of $98.47 to be implemented to the current ambulance rates on April 1st. An extraordinary rate increase is allowed for section 17.5 of the current agreement. That section also prescribes the process by which these requests are submitted to the EMS agency. We prepared a response on what are the next steps that need to be followed for us to be able to review and do our due diligence before a decision is made to take that to the Board of Supervisors for approval. Let's see, I think this item is in, yes. I think another area that we started working on with AMR is in looking at the fee forgiveness program. We received a report from them on the use of the fee forgiveness program. We made some suggestions for changes to the brochure that is being used, so that it describes more the local program. We think that it's maybe a little too general, but it's not unusual for companies such as AMR to use a more general brochure for certain programs that they describe. Estela, do you mind bringing the PowerPoint? I'll just do a quick review of that, just to let you know that it is something that we can also continue to bring a report to this committee in the future. Things that we catch as we comb through the agreement, we try to add them to the contract compliance working group and then bring them here to see if there's a need for us to, if an interest or a need for the committee to see this type of report. So the fee forgiveness program in the agreement says that the contractor agrees to forgive and waive annually $1 million of uninsured and self-pay accounts. It also says that, we should review that periodically. I don't think that has been done in a very long time. You can go to the next slide. Okay, so here are the requirements of the program. The patient must be a resident of Monterey County, and the patient must be picked up and transported within Monterey County. The patient must meet medical necessity criteria and must be uninsured or have no third-party coverage. The risk would be a substantial burden to that patient. Just summarizing, go to the next one. So here are the discounts that are allowed per this program in the agreement. So there's one for an 80% discount of the bill charges, another one for 50% discount. And it provides, this is language directly from the contract and how that is applied. So we received a report from AMR on this program. So that the area on the left, you see that 80% discount and that 50% discount, and you see the report of how the amount that has been used each year. It does look underutilized. However, let me just say that AMR is not, these are not the only programs that AMR has in the county or even, company-wide. That compassionate care program that you see on the right, it is not one that is covered under the contract, but you see that it is an additional program that AMR has, and they do forgive additional amounts on those bill charges. And there's also a lot of something that we don't hear about a lot. It is all of those unpaid accounts and what happens to those that, eventually, I guess they write off. But we wanted to give you a report because it is prescribed in the agreement. And I can answer any questions you may have.
Oh, hi there. Yeah, and I just wanted to, illustrate that this, what you're looking at is very, very specific just to the fee forgiveness program, but certainly, we do our best to work with patients, including, alternate payment, programs, things like that. So I just wanted to make clear that this doesn't really illustrate all of the write-offs that we do, and it's all specific to fee forgiveness. Thank you.
Thank you, Mike. Okay. Anything else? Not as an emergency. Okay. Okay, anybody have any questions for Teresa before we move on?
Not a question, but a comment basically on what this is Luz, on what I've seen as a provider, that is one of the main concerns for the patients being transported to a local hospital, and if they actually go or not by ambulance, and it is certainly the cost that's always brought up. So is this fee forgiveness program something that is brought up by paramedics as an alternative and a choice, as far as for patients, so that they could actually say, be more inclined to say, yes, I'll go by ambulance because it's medically necessary? Is it brought up? Like, yes, we understand that there is, that there's a cost, but there's some programs that, could be forgiving, the fee, and you could, that could be addressed. Is that something that?
I think it would be a fair statement that, we do not encourage our paramedics to discuss, payment options on scene. Our entire goal is, focused on their clinical care, not to discourage or encourage anybody, based on their ability to pay or to do any type of field screening. Our billing office definitely works with the patients and, does their best to help them navigate the different programs that we have, to make it as, convenient and, as helpful as possible through that process. But we would never on scene, try to qualify patients, or, the decisions really have to be medically indicated as to whether or not we would do that transport. We don't want, the ability to pay to ever come into decision at any level in decisions whether or not to go to the hospital.
And we did discuss that with AMR at the meeting where we were looking at this report. Can you go to the next slide? And so AMR does have a brochure, as I mentioned earlier. This is the brochure that is online. So we did talk about by which means do they make this information known to the community. And, Mike, he told us what you just heard. We looked at the brochure, and we know that it is available on our website. I believe, Mike, if you can correct me if I'm wrong, but it is not available on AMR's website. So working on a good way to disseminate the information so that individuals who need it can take advantage of this program, I think is something that we will continue to discuss. We made suggestions to the brochure itself because, just even looking at the title of the brochure, it says paramedic and ambulance transportation services. The focus, the description of the fee forgiveness program, I think is 1 or 2 paragraphs on that in the red area. The next page, the rest of the brochure talks about, who determines the rates, what does the insurance cover? It does provide a good list of other resources. So we presented AMR with some suggestions for that so that it maybe could be made a little bit more specific to Monterey County and looking at the ways that would be appropriate for the dissemination of the information to residents of this county, since this program does exist. We can report on this in the future.
Jim, did you have a question?
Just a comment. It's all very useful information, and just the recommendation that if this were also done in Spanish, I think that would be helpful to many residents in the South County area as well.
That is the other recommendation that we made to AMR.
We have another one, Sharon Henry.
Yes.
Sharon Henry.
Hi, I'm with AMR. I just wanted to also let you know that since the beginning of 2020, the first mailer that goes out to patients has a COVID alert with some language that says, if you've been impacted financially by COVID, call us, let us know what's going on so that we can, use special resources to work with people. And it kind of fits with Mike's point that the data on that slide with the fee forgiveness doesn't reflect all of the write-offs, right? A lot of that happens in the phone conversations with the billing specialists. So we're trying to be especially sensitive during these difficult times of COVID. That's it.
Yeah, and the EMS agency has acknowledged that. That's one of the reasons why in providing this report with the table that we provided, we also included that AMR's compassionate care that is not part of the county specific programs, but it is part of what they do, and we do know that they do more.
No, I think that's great, and I can see right here we need, we could update some things. Writing it, putting it in Spanish, it seems perfectly appropriate. So I appreciate those comments and thoughts.
Jody?
Okay.
Yeah, question, comment?
Yeah, I really appreciate Luz's comment about when on scene, patients are reluctant to go because of the cost. I also totally appreciate Mike's comment about it's not really a good place for the paramedic to be discussing cost options. And nobody wakes up in the morning planning to call 911. So it's about getting this public service out, knowledge to the community ahead of time so that in the event someone needs to call 911, they know they have an option if they qualify.
I agree with that. I agree with what Jody just said.
And just on behalf of the fire department system in Monterey County, it's exactly consistent to Mike's points. We instruct all of our employees not to discuss billing on the scene.
And that is why we want to explore the ways that, if it is disseminating the brochures in English and Spanish, what is the appropriate way to do that? We totally understand the point from Mike's, from AMR, that they don't want their paramedics. Paramedics should be providing the care that the patient needs, not talking, payment options.
Yeah, maybe the county or AMR could get together and do some PSAs, put something out ahead of time so people are more aware. And the community, once they find out, they'll talk to their friends and neighbors.
It is one of the agenda items at our next meeting, just exploring the appropriate ways to disseminate this information.
Great. Anybody else?
And this is Mike, if I could just make one final comment. You know, and it really is critical to illustrate that we make such a dedicated effort to be good advocates for the patients. So if they do, you know, communicate that they have a challenge in their ability to pay, we also have a patient advocate that we employ out of our billing office that is somewhat local anyways, who's bilingual and able to help those patients sort of navigate the process and work with them to see, you know, what best program fits the need of the patient, and, you know, reasonable payment plans and all of those things that they can explore in helping them find ways to pay for their trip. So thank you.
Great, thank you. Any other questions or comments for Teresa and her EMS agency report? Okay, we will move to item D under number 4, and that's the report of our MOAC, Mr. Jeff DeAndrea for COVID-19.
Hello, everybody. Since our last EMCC meeting, the MOAC role has been, much of it has been focused on authorizing EMTs and paramedics from fire departments to act as vaccinators to get that training. That's been a partnership. My colleague, Steve Brooks here, worked with the state quite a bit to get that program set up. And then I've been working with fire chiefs to get them through the process so that their personnel are authorized. It's been, I should add, it's been a great opportunity for me to get to know some of the chiefs through various conversations and working with them. At this point, we have 138 EMTs and paramedics from 9 fire departments that are authorized to administer vaccines. And the recent development is the inclusion of the Johnson & Johnson vaccine, which is great news for the fire departments potentially, because most of the fire departments did not choose to become vaccine providers, which means that they could receive and store vaccines. But the attributes of the Johnson & Johnson, the third and newest vaccine, sort of circumvents a lot of those requirements, ultra low temperature storage, the freezers, and a lot of the burden and investment associated with the other vaccines. So there's hope in the future, in the weeks to come, actually, for maybe some fire departments becoming providers and being able to receive vaccine doses directly. So that process of authorizing personnel is continuing, but it's pretty much winding up because most of the fire departments in the county are on board, that are going to be on board. Otherwise, the Mohawk resource request program continues. Whereas it was just PPE for the most part months ago, we've sort of diversified into various things. Carla, we just got some more concrete barriers.
Oh, thank you.
Over there for you the other day. So anything safety related, we can make requests of various agencies to take care of. We've handled over 1,500 requests for various products. And now we're with the vaccination efforts, we're moving into needles, syringes, sharps containers, and so forth. And then lastly, I'll add that we had a little bit of a breakthrough in late January with some very proactive coordination. Deborah and I, we sat in on 4 straight days during the weather event in late January with Bay Area, MOACs, the regional coordinators, and the EMS Authority, Brad Gates from the EMS Authority. And we just sort of got all on the same page, enhanced our preparedness and readiness for any events, because there was a lot of concern regarding the heavy rains over the burn scars and a lot of the debris flow we were expecting. Things turned out a little much better than feared. So that sort of created a little template for future weather events and just being prepared ahead of time and getting all the various MOACs in the Bay Area and the Central Coast on the same page and prepared. And that's all I've got for you right now. If there's any questions. Okay.
I have to say, after we experienced a car going through our tent, that's when we decided to put concrete barriers around all of the tents so that we can keep that from happening and keep everybody safe. So yes, thank you, Jeff. Kind of a strange topic. Nick, it looks like you're off mute. Did you have a question or comment?
No, sorry.
Any other questions, comments for Jeff? Yes, that was a no. Okay, we'll move into our item E, Contract Compliance Working Group with Ms. Kimberly Hernandez.
Good morning, everyone. Are you pulling up the PowerPoint? Just one moment. Okay, so for contract compliance, you can go ahead and go to the first slide still. For response time compliance by priority for the months of November, December, and January, priorities 2 through 6 exceeded the 90% compliance. Priority 1 for November was 83%, December was 84%, January was 89%. And I would like to note that there was no there could be no rounding when calculating compliance. January's percentage for priority 1 was 89.84%. AMR came very close to making priority 1 compliance for January, and we would like to recognize their continued efforts. You can go ahead and go to the next slide. For response time compliance in the green response area for November, priorities 2, 3, 4, and 5 exceeded 90% compliance. Priority 1 was at 82%. Priority 6 compliance was not reported for December as it had not met the 100 call rule for the month. For December, priorities 2, 3, and 4 exceeded 90% compliance. Priority 1 was at 85%, and priority 5 and 6 were not reported for December as they had not met the 100 call rule for the month. For January, priority 1, 2, 3, and 4 exceeded 90% compliance, noting that priority 1 was at 91%. Priority 5 and 6 compliance were not reported for January as they had not met the 100 call rule for the month. And response time compliance for the yellow response area. Priorities 2 and 3 exceeded 90% compliance. Priority 1 was at 84%. Priorities 4, 5, and 6 were not reported for November as they had not met the 100 call rule. For December, priorities 2, 3, and 4 exceeded 90% compliance. Priorities 1, 5, and 6 were not reported as they had not met the 100 call rule. And for January, priority 2 and 3 exceeded 90% compliance. Priority 1 was at 85%. Priorities 4, 5, and 6 were not reported as they had not met the 100 call rule. Good. And for response time compliance for the orange response area, the only priority that was able to be reported in the recent months was priority 2 in December at 97%. All other priorities were not reported in November, December, or January as they had not met the 100 call rule. And for EMS dispatch performance continues to be well below the 59-second standard. 38 seconds for both priority 1 and 2, and 33 seconds for priority 3. And these slides just contain definitions. You can just go through them. Any questions?
Maybe you want to stay, it looks like our.
I'm going to do another PowerPoint.
Another PowerPoint, yes. So the other provider response time reports are in the packet.
Actually, I'm doing one on the, I'm sorry.
Oh, you're doing one on that one too?
No, on medical priority dispatch system.
Oh, okay.
It's part of the compliance.
Oh, yeah, I'm sorry.
That's okay.
When this is Mike, I was hoping that I could make just a quick comment as well, if that's possible.
The other providers.
You have a request from Mike to make a comment.
Okay, go ahead, Mike.
Yeah, I just wanted to highlight that, while we've been in disagreement over the new MPDS standards that were implemented back in November of 2019, not necessarily with the standards themselves, but utilizing that metric as a standalone, compliance measure. We do appreciate, us having a voice and being able to bring some of those concerns to the committee. And we do have a meeting, which looks like that it's going to be coming up here very quickly with the EMS agency. And we'll have the ability to re-examine the metric and also come up with some ideas with maybe a more reasonable, measure or way to measure that response time performance. I think that it doesn't provide an accurate report card of the system overall. When you look at those numbers, I mean, for me to see 83% in a priority one measure, that's a terrible number, so to speak. But I think that, overall, just to be very clear for everybody who may not be aware, we're talking a very low volume of calls here. It's less than 10 calls a day. Typically, that standard that we're late for maybe one call, per day. So it's not a large volume that we're looking at. So I appreciate everybody's time and willingness to, re-examine this in a more, closer light. Thank you.
Yeah, I think that from the EMS agency perspective, we don't see that we are, that our positions are contrary to each other. From the beginning, we have said that we put it on the amendment number 10 when we extended the current contract. And we knew that changes to the call prioritization were made. First, we waived penalties for a period of 6 months because we knew that the calls were going to be shifting and we didn't know what that shift was going to do. So we were going to watch the data and then come to the table to see what, if any, changes needed to be made. But nobody expected COVID. And then nobody expected the fires that came after that. So what the EMS agency acknowledges is that those are variables that have gone into this data that affects the compliance. We meet monthly with AMR, and when we talk about the things that have affected their ability to meet response to compliance, the extended APOT times, the time that it takes to decon a unit, those are things that come up. So we know that those are variables that are affecting the response time. When AMR did approach the agency about changing the way that the calls are, the response time compliance is measured, we did say that we were open. I believe that at this meeting with this group in January and in December, the EMS agency stated that we would be open to discussing a different way. I believe at one of the meetings, Michael proposed combining priority one and priority two for the purpose of response time compliance. And we started to have some questions. We requested AMR to show us what that looked like, exactly what they were proposing. AMR acknowledged there was a sense that at least somebody interpreted that as we're combining the two and getting rid of the 8-minute response time. And he clarified, no, that's not what we mean. And so we said, then show it to us. Take the data from any month or several months and show us what you are proposing. So, everybody right now with COVID and everything is very busy. So we have not been able to come to the table as quickly as we wanted to. But we are more than willing to work with AMR. We want to do what is right for the system. But I have said in previous meetings, the EMS agency has to do its due diligence before agreeing to a change. So we need to ask the questions. We want to sit down with AMR. We want to see exactly what it looks like, what they are proposing. We did meet with them a few weeks ago. They showed us the way that the different scenarios that they ran, the analysis that they did, and that was very helpful. But we still are expecting to see something a little bit more formal, a formal proposal from them, and then really to show us what does it mean. The combining priority 1 and priority 2 into a single bucket in the simplest form does help to eliminate any penalties, because now you have a big bucket with a high call volume that would prevent AMR from falling below that 90%, especially when you have the 2 priorities combined. But what the agency wants to make sure is that we are still able to monitor those calls, especially the high acuity calls. In the simplest form, combining the 2 may hide that, because now the response time compliance is at 90% or above, so everything looks good. What we want is just is to make sure that we don't lose sight of those high acuity calls. We are open to discussing any proposed change the AMR has, but we need to see what that means and before we move forward. But I think that we have worked well in trying to figure out a way to solve this issue.
One thing I think that is germane to note here is that the contract compliance working group has looked very closely at those calls which were not in compliance and the percentages of those and what they are: 1 minute late, 2 minutes late, 3 minutes late, whatever have you. And quite frankly, when we consider the impacts of COVID and the recent fire commitments, I do not see any major concerns there. Obviously, any late call is a concern, but I don't see trends there that are alarming to any extent. So this is not being looked at in just an overview posture. It's being looked at in detail.
Thank you, Harry, for bringing that up, and not to put you on the spot, Kimberly, but could you talk a little bit about that, that analysis that you've done?
So for the contract compliance working group, I did a priority 1 drill down. So I took all the late priority 1 calls for the contract compliance working group. I did it for October, November, and December. And I took the raw late calls from the Tri-Tech County Com CAD. And then I took all of those calls and sorted them into time intervals where they were 0 to 1 minute late, 1 to 3 minutes late, 3 to 5 minutes late, 5+ minutes late. I also put how many were in each zone, how many of these priority 1 late calls were in each zone. I also went further in how many the time intervals in each zone. And also how these calls were canceled. Meaning, did they transport code 2? Did they transport code 3, lights and sirens? Were they canceled on scene by an AMA? All the cancellation reasons, how these calls ended up. And then I went further and I also, of the calls that were code 3 returns, meaning they left the scene code 3, which to me are the highest acuity calls of those priority 1 calls because they had to go code 3 to the hospital. Of those calls, how late were those calls? So I broke those down into time intervals as well.
Yeah, and part of what we're looking for with that analysis is we want to, of concern would be if we see the majority of calls or a high number of calls that are 5 minutes or more late. But what we are seeing is that when they're late, they may, a good number of them, and there aren't that many calls. Let's just start by saying that. But they are less than 1 minute late or between 1 and 3 minutes late.
Most of them are 3 minutes or less. It depends on the month. Some are in the 1 to 3 minute is higher than the 0 to 1, but the majority are 3 minutes or less late. And the majority of these calls being transported are code 2. And I don't have the numbers in front of me, but the percentage of calls that are being transported code 3 are much smaller.
Wait, so 1 second, like is 25% was the number I saw that are transported code 3?
I don't have the numbers in front of me.
Okay, because I mean, it's still a very sick subset of patients, right? Which I think is kind of getting lost, right? So 20, I mean, what's the code 3 rate to the hospital? I think it's like 5-7% usually, right? So these patients are 5 times sicker than the average call.
Unfortunately, I can't, I'd have to go back and look at those months to see, but I know that the majority, again, I don't have the numbers in front of me. The majority were transported code 2. There were also other reasons they were canceled because the patient canceled on scene, AMA, canceled by fire. And then there was a percentage of transported code 3, but.
Because here's my concern. So this is our sickest subgroup of patients. And this is why I think we have a 911 EMS system, right? Is to provide to the sickest patients. And if it's a statistical thing that there are enough calls in 1 month, then maybe we should pool them and look at them by quarter. But I'm not a fan of combining the priority 1 and 2 calls together, because I think you're going to lose looking at the sickest subset of patients, which I think is highly important.
And that's exactly, Dr. Greenson, the point that I made about just combining priority 1 and priority 2. And, our focus is, to make sure that the patients are getting the care that they need. So this is the first time that we are drilling down into the data this way, so that we really look at what is happening to those calls that are late. Because in one of the reasons that you, Dr. Greenson, emailed us after one of the presentations at Contra Compliance, we were already starting to look at the data, but we drill down more to try to answer some of your questions. What we want to make sure is that out of that, what I want to make sure is that we're not thinking that there are many calls that are late. Of the few calls that are late, how late are they? So what we wanted to make sure is that they're not on the other end of the spectrum, where they're more than 5 minutes late. If we saw that, then we know that we have to address that. Then we would be working with AMR. When we see shorter times that they're late, then it is of less concern. We still have to look at that, but it would be of more concern if we see that they're 5 minutes or longer late. So we are still working with AMR. We start looking at the data. We want to keep an eye on this. We'll continue to work, and I'm sorry because I'm being unfair to you, Kimberly, by asking you to talk about data that is not in front of you. But just as a process, we wanted to make sure that the committee knows that we are looking into the data with AMR. They have been very cooperative and answering the questions, and us looking at the breakdowns and kind of validating each other's work, to make sure that the way that we're looking at the data doesn't have any, red flags. At the same time, we do that with the reports that they send to us every month.
No, and listen, I totally acknowledge, I mean, COVID has been disruptive in every way imaginable, right? But I don't want to lose sight of this, and I don't really care about the past year. It's just going frontwards. I think we really should keep an eye on this, and it should remain a priority to have the call response times be within national standards for the tier 1 patients.
Yeah, we're looking at this every month, Dr. Greenson. We will continue to report. When we started looking at this, we did go back just to get an idea. We did a comparison of the response times before and after, before COVID, just to get an idea, and then during COVID, so that we could see the differences. We started doing different analysis, just looking at from the moment that COVID hit, and what that has done. I can tell you that with 100% certainty that we have not looked at the data this way at this agency in the time that I have been here. So we're doing a lot more to analyze data, and Kimberly's expertise in this area has been very helpful, as it has been Roxanne, to have her on board and help us crunch numbers and everything.
No, I totally appreciate all the hard work you guys have done. And there's been, and the data's been, I really appreciate you guys retrieving all that. And, I think we're headed in the right direction. Let's just make sure this doesn't fall off our, from our view.
That is our goal, to not lose sight of it. Thank you.
I just had a question at some point.
Okay, so in the interest of time, because it is 11:30 and we have a bit more in the agenda, Mike, do you want to ask your question really quick, or do you want Kimberly to continue with this next presentation?
Yeah, I don't know if that other presentation was going to actually occur today, but the question I have is for AMR, because obviously they provide service all over the nation. Have they seen this Monterey County standalone metric of excluding 10 calls or less in a priority one in a rural system? Do you see that anywhere else in your contracts throughout the nation?
The honest answer is that we did look at that. We were not able to identify any other systems in the state of California that had similar benchmarks, at least in a system that was non-subsidized. I believe Mesa, Arizona, and Las Vegas both have similar systems, but obviously, the geography and those dynamics are considerably different. And again, just as a point of clarification, we are certainly in no way looking to not have those calls reported. I think just the challenge for us is that when you're looking at a standard that's 0.7 calls a day, that's a breachable standard. It gives the false impression of the overall performance of the system. And while there's certainly high acuity calls and ones that we're committed to providing exceptional services to, the challenge comes around building an entire system around those 25 calls a month. And that's where it gets really complicated, and just the unit hours, the staffing, and the coverage required to meet that small fraction of calls. But certainly we're committed, and not in any way recommending that we would not report that standard. It's just in terms of our our performance metric. That's what we're looking at primarily.
And the one, I think, to Dr. Greenston's points, I think right on it, is if we can drill down to those calls that are critical, but their volume's not large. The one thing that we're not looking at is the fire department-based paramedics getting on scene, right? We have 18 fire stations in Monterey County that provide paramedics, right, in highly populated areas. So we need to have that data to showing that when we get paramedics on scene within 6 minutes, and your ambulances are arriving at 12. See, we're painting this picture just based on your back. We're not looking at the partnerships that we provide and our taxpayers are paying.
That's right.
And
exactly.
We're using a Las Vegas and Mesa, Arizona standard in a rural county, and we're not even getting credit by providing paramedics to our constituents, the partnerships that we have with yourself. And I think that's the next step, is we're painting a picture. And I think for everybody on the EMCC to understand, when AMR came back in 2009 after WestMed, this is not the standard they bid. This is not the standard they agreed to. This standard was changed when we adopted the MPDS. So we took a rural county and we put a Mesa, Arizona and a Las Vegas standard. We didn't do the due diligence by the partnerships of our advanced life support fire department based systems. And I hope we can do that in the future. Thank you.
Thank you.
You can go ahead and, so I wanted to talk a little bit about the medical priority dispatch system, on how percentage of calls EMD is calculated. Currently, the way percentage of calls EMD is calculated is by taking the total of calls EMD, calls that have a determinant code assigned, and dividing it by the total call volume. The current calculation does not take into consideration that a portion of these calls are being put into the equation but are never received by AMR for EMD. Some of these examples are structure fires, 5150s, interfacility transfers, water rescues, cliff rescues, police on scene requesting an ambulance, and fire on scene requesting an ambulance. These call types require an ambulance response but will never be EMD'd. Depending on the volume of these call types each month, or I'm sorry, every month, they could affect the percentage of calls not EMD'd, which would paint an inaccurate picture. You can go ahead and go to the next slide. On this slide, it shows the calculations. The current calculation is what I spoke on before, is the percentage of calls EMD divided by the total call volume. So just based on a month, it was at 53%. If we use the proposed calculation, which would take the calls that are never EMD'd off the top, it would create a total call volume that's adjusted. And just by doing that, just changing just that variable in the calculation immediately shows an 8% increase in the calls EMD, and more accurately it depicts the number of calls EMD'd. Go ahead and go to the next slide. So there's also another call type I want to talk about, but first I would like to go over the anatomy of the EMD during COVID-19. So step one in EMD is the case entry. The case entry protocol standardizes the beginning of each call and functions as an initial caller interrogation. It directs the call taker to collect essential information for initial processing and classifying of the incident, including the chief complaint, age, sex, and status of consciousness and breathing. A dispatch determinant code will be assigned during case entry for high acuity calls such as cardiac arrest, active choking, drowning, and hanging. Step two during COVID is the EIDS tool screening, only used during widespread transmission of an infectious disease like SARS, H1N1, Ebola, and COVID-19. The EIDS tool enables EMS authorities to implement an enhanced medical dispatch caller screening protocol for a specific disease outbreak. A positive answer to one or more screening questions activates a warning to alert responders there is a reasonable likelihood of an infectious disease. The EIDS tool extends the time it takes for the dispatcher to get into the next step, which is key questions. Key questions provide a secondary caller interrogation. The answers to these questions help the call taker assess scene safety, prioritize the response, select appropriate caller instructions, and provide pertinent information to responders. The call taker uses these answers to these questions to automatically assign the appropriate dispatch determinant code. Most determinant codes are assigned upon completion of key questions. Because the EIDS tool extends the time it takes them to get into the key questions, it has been resulting in more aborted calls with the help arrived abort type. Go to the next slide. So aborted calls, what are they and how are they treated? Aborted calls are what are calls that were transferred for EMD but were terminated or aborted prior to getting a determinant code. The most common abort type is help arrived, which means fire, police, or ambulance arrived at scene, and the dispatcher had to terminate the call during the EMD process before a determinant code was assigned to the call. The percentage of aborted calls has increased significantly since the start of COVID-19. AMR dispatch is utilizing the EIDS tool for responder safety, resulting in lengthier interrogation process. Currently, aborted calls are lumped into the generic medical call type, where it is hard to distinguish if a call has been transferred for EMD or not. Treating these calls differently will help us drill down even further into the medical call type to more accurately see what percentage of calls were truly received for EMD. Currently, all aborted calls are considered not EMD'd. Go ahead to the next one. But the question is, should help arrived aborted calls be treated differently? Aborted calls with help arrived are not counted as EMD calls because the dispatcher did not get a determinant code. However, the patient got the help he or she needed from fire, police, or ambulance. Should these calls be treated differently? And the options for consideration is treat aborted calls with help arrived abort type as EMD'd since the dispatcher could go no further in the interrogation process and the call was EMD'd up to the point that help arrived. They were unable to go any further in the EMD process to code the call with a determinant code. Or remove help arrived aborted call types from total call volume along with the call types that will never be EMD'd to create an adjusted total call volume. And you can go ahead and okay, changing the calculation of the EMD'd calls. At the EMCC's request, item is being brought back for endorsement to change the way percentage of calls is being calculated. At the January meeting, the committee members supported changing the calculation by removing calls that will never be EMD'd from the total before calculating percentage of calls EMD to create an adjusted total call volume. Given what we have learned regarding aborted calls where help has arrived, should the new calculation also remove the aborted calls where help arrived to further adjust the total call volume, or should they be considered EMD'd? Any questions? That's all.
Well, how do we go about implementing that?
Well, it would be just a matter of changing the formula for the calculation. And the reason why we started looking at this issue is that right after the implementation of that call interrogation, we saw that percentage of calls EMD go up, but then they started to go down. And so we started looking as to the reason why, working with AMI, of course. And that's when we found out all the information that Kimberly just presented to you. We reached out to, what is the name of the agency again? I'm sorry.
Oh,
Academy?
the International Academy of Emergency Dispatch.
To see if there are any rules about how to calculate the percentage of calls that go through EMD, and they are not. It is up to each individual agency how they decide how to count them. But we kind of ran these scenarios by them and by the individual we were talking to, and he said, yeah, it makes sense, you know, that those would be definitely the calls that will never be EMD'd. It's like, why are you even counting them? And then the ones that are aborted because help arrived, that, you know, it makes sense to treat them, you know, one of the two ways in which we are proposing.
Well, considering that the goal is to get as many calls as possible, we've not set a percentage, but I'll say as many as possible EMD. In the practical sense, these calls are being EMD by someone on scene. So what's the difference? The EMD process is being accomplished. So I would say implement consider them EMD'd, or the second point, take the first bullet and consider that. But, you know, and let's have a trial period to see what it does to our figures, or implement it, period. It seems to be practical to me.
Yeah, we can make the change, implement the change, and then report back to the committee.
Let's make the change and monitor it for a 6-month period or something of that nature and see what it does.
Can I jump in here as with some input from the 911 side?
Please.
I first and foremost applaud this deep dive that I believe Kimberly was able to do with her experience of sitting in the chair. And it definitely shows the hard work that the EMS dispatchers are doing. I would like to support these calls being almost put in a third category, remove them as aborted calls, but not necessarily consider them EMD or quasi-EMD. And the reason I say this is because if you consider them EMD, you're not seeing the true value of how many calls we're able to be fully EMD'd versus partially EMD'd. So for the long-term quality assurance of the EMD process, considering them EMD'd, you'd be losing some really good data, and it would help whoever the EMS provider is advocate for additional staffing. Because if they are all considered done, then you're going to assume your staffing is okay. And I can guarantee that at times you probably need more staffing, but you would need to measure it with this metric. Thank you.
Those are germane considerations. Why not move them out of the total volume of calls then? But keep the statistics. That's what I'm hearing you say.
We can create a separate column and report those separately, and monitor, continue to report to the EMCC. We will remove the ones that they will never EMD, and then create a separate column for the call type aborted calls where help arrived, so that we can keep an eye on those. And report accordingly beginning the next EMCC meeting.
One other thing, and I may be wrong on this, but I believe inter-facility calls, it's just a decision not to do EMD. The EMS dispatcher is receiving those calls and doing the Q&A. So just from my perspective as the first half of all the calls, I don't believe we're triaging those. I think that AMR is still triaging those. And so in some ways, I think they should get credit for those because it's another call that they are actually handling. And I see Mike nodding his head. So at least I feel good that I'm right when I say that.
I totally agree. I mean, I believe that those calls are actually being triaged and screened and going through the EMD process. So they should get credit for that.
Yeah, Kimberly.
Well, the ones that we're talking about are not, are you referring to card 33? Mike?
Yeah, I mean,
Exactly.
yeah, interfacility, I would think that you would be using the 33 card, or you have a local protocol that says when they call and ask for an interfacility, you're just not EMDing it, but you're still processing it by your local protocol, which means it satisfies EMD.
Yeah, it's card 33 and I've reviewed it, and that's the magic of it is that, you know, there's the ability to kick it out of that process if there's any type of criteria where it requires an immediate response or something beyond just an IFT transport.
So in the beginning of the PowerPoint, when we're talking about interfacility transfers, it's not the card 33 because those are getting counted as EMD because they have a determinant code. It's the calls that are like chunk calls for a transport to SVMH and it's built like an actual transfer. Those are being put in the calculation. So we want to take those off the top because those are never EMD'd.
And Kimberly, to my point is when I look at those aborted call or the calls that are never processed, I look at all those that my department's holding back from you. And so I'm just saying those interfacilities are something that my dispatcher's not holding back from the ambulance dispatcher. So they should be looked at as a call that the EMS dispatcher actually is handling. They are processing it. They just don't happen to process it with EMD.
And they're still being screened.
Mm-hmm.
We can go back to and look at that. Okay. But if the committee, oh, I'm sorry.
Sandra Flores has a question.
Sandra Flores have a question?
No, this is Sandra with AMR Dispatch Supervisor. I think what Kim's talking about as far as the interfacility transfers, it's those priority 4, 5, and 6s. Is that correct, Kim?
Yes. Yes. And it's not that AMR wouldn't get credit for them, but in the purpose of just knowing what calls were EMD'd and not EMD'd is taking those off the top because they're getting counted as not EMD'd when they're never going to be EMD'd.
Could those be considered to be placed in a bucket in their own group, like those aborted cases and then those priority 4, 5, and 6s, because they are being interrogated in the sense of getting all the patient information to ensure that we're providing good patient care or the appropriate patient care.
Okay. Well, we'll implement something and then start reporting that in May.
Okay.
Based on the feedback. Thank you, Kim.
Okay, thank you. Okay, on to the next topic, letter F, we have Roxanne that's going to give us a report of the other providers on the response times.
Okay, can I have the ability to share my screen, please? Thanks. So today I'm going to be presenting to you the 90th percentile response time for Carmel Fire Ambulance, and I will do that as soon as I can share my screen.
I think she would like to share her screen.
And so while she does that, if I may, this committee has requested for the EMS agency to bring reports on response time for the other ambulance providers in the county. We started working on that and then COVID hit. And we were able to come back to that just recently. Roxanne prepared the reports for Carmel Fire Ambulance and for Monterey County Regional Fire District. We wanted to meet with those two agencies before bringing the information to this committee. And we met with Chief Tomasi and also with Chief Urquidez. Chief Tomasi was comfortable with the data, provided that we put it in the right context. Chief Urquidez had more questions on the data, partly because one, he wanted to validate his numbers with ours, and also because and please correct me if I'm wrong, Chief Urquidez, but I believe that some of his reports may not be reported on the 90th percentile. They may be provided as averages. So there's already going to be a difference in the response time that he reports versus the response time that we used. Roxanne will go into why the 90th percentile versus the average during her presentation.
Okay, thanks, Teresa.
Okay, so the purpose of this high-level analysis is to just present a picture of the 90th percentile response times by Carmel Fire Ambulance around Monterey County. I just do want to start by saying there is no standard for 90th percentile. This is just using this method to look at responses. So to conduct this analysis, I extracted data from the Emergency Communications Department Computer-Aided Dispatch System, or I'll refer to it as the CAD, which is used across systems to document several response times in, to document like there's need, like so the type of medical call, the and then time specific data, so the time the call was reported, the location, and other data elements that's used for this analysis. So the CAD does not include response time into Kashawa. So for the purpose of this analysis, I excluded the calls into this region. Carmel Fire just have a small number of responses into that. So I just decided to exclude it because it can impact the times that we see if I did. And then because we wanted to focus like on the area and immediately surrounding areas, another reason why Kashawa was not included. So once this data was collected in its raw format, I specifically looked for medically related calls directly linked to the ambulance units. So the information from the CAD specifically identifies medically related codes and includes the dispatch date, the time arrived on scene, and then the incident number. So the incident number is a unique identifier for that call. And that's important because when I was looking to calculate response times, if multiple units were dispatched, they all have the same incident number. So it would have looking for the first dispatch time and then the first unit to arrive on scene. So using the difference between that is how I calculated each response time interval. And then from the response time interval, the 90th percentile measure was then calculated per month. And then you'll see in the slides that the 90th percentile was then looked at by overall response times per month, by the response area, the jurisdiction for Carmel, and that's identified in the CAD, and then also by mutual aid, again excluding Kashawa, and then by the city of Carmel by the sea response area only. So the data these are some data considerations that I think is very important to remember as we go through the slides, is that the data was analyzed using information from the CAD. So the CAD identifies Carmel's response area as MNT, as you'll see on the screen. And it can be, it is actually a greater response area than the 93921 used in many existing reports by Carmel. And there is a known lag time between the time the call is dispatched from 911 communications to County Com and then returned, which may contribute to the dispatch time that's reported. So this impacts the individual response time interval, but to the degree to be honest, I'm not really sure because the CAD system is taking the county communications time. So that's what this analysis is based on. This analysis is again limited by the information in the CAD. The Carmel by the Sea will have both 93921 and 93923 zip codes. And that's important because Carmel Fire response times when they report it is by averages, and also only includes the 93921 zip code, where when I was doing my analysis, I looked for any calls in the city of Carmel by the Sea. The total call volumes should be a consideration when looking at the 90th percentile response time calculations. Statistically unstable results may present itself because of the variations in small responses, small numbers. And also, again, I know we said this multiple times, recognizing that COVID-19 pandemic and the wildfires around Monterey County has impacted the total number of calls that we see and response times in certain months. But it's a notable system-wide impact. Okay, so data summary here. So
my analysis drew 2,050 calls during this reporting period. And I'm sorry, I didn't mention this. It's between January 2019 and December 2020. And of those, 832 calls were in the fire ambulance response area, which again is the CAD identified MNT. And 1,218 were outside of that area, and 853 were in the city of Carmel by the Sea, not just the 93921 zip code. Okay, so the first slide that you're looking at is the overall response time by month. This includes the response times for Carmel Fire Ambulance units. It includes the mutual aid responses, again, excluding Peshawar, and responses in and out of the 93921 zip code. On average, there were about 85 calls per month. The trend shows a 98th percentile at around 9.5 minutes. And I also did this statistical analysis. It's called a regression analysis. And it's really just to see if the changes that we're seeing between 2019 and 2020 are significant in nature. However, it's because the p-value is greater, I cannot say statistically speaking that there is a significant change in call volume or in response time over this time period. Did I hit next? Okay, so now this one is just, again, within that fire response area identified in the CAD. It's greater than that 1 square mile 93921. And the average call volume, sorry, I used the word average. I should not have done that. But there's about 34 calls per month. And the 90th percentile is about 6.5 minutes or 6.5 minutes per month. The results of this slide should be interpreted with caution because you'll see that there are some months where the call volumes, well, the call volume in all months actually are statistically low. So any increase in call volume can change the results that you do see in future reports like this. This is looking at mutual aid, again, excluding Peshawar, and during the same time period. So mutual aid, about 50 calls per month, and 90th percentile is around 10.5 minutes. And again, low call volumes here should be interpreted with caution. Switching into the Carmel by the Sea response area, this is, you'll see it's about 35 calls into the city and within 90th percentile around 6 minutes. There is some variation here. You'll see increases in certain months, but again, low call volumes, you want to really take that into consideration when interpreting what it means month to month or overall. That is it. So to summarize, the 90th percentile, it ranges between like 6 minutes, 10.5, depending on which response area we're looking at, whether it's within the fire zone or outside of the fire zone, or just by the city. And these numbers are higher than the average that's reported by Carmel Fire, and that's because averages are just a different measure, and also it includes a wider response area. So taking these things into consideration is really important, and I believe that is all that I have for now. Does anyone have any questions?
Roxanne, I would have one. So the Mid-Coast Fire Response Area is considered a mutual aid area because of the long response times down to our fire district.
Mm-hmm. So if the information for that would be stored in CAL FIRE reports, so I included, it would not be in this report. If it's not in the CAD, then it's not there, and I believe Mid-Coast is CAL FIRE, is that correct?
Yes, we're dispatched
Yeah.
by fire.
Okay, yeah. So I'll make that clarification that if any of the medical incident reports are CAL FIRE, then it's not in this report. It's specifically all stuff that's taken out of the CAD. So some calls would be included in.
Roxanne, I just had a question. Again, this is very helpful now to see the 90 percentile for the city of Carmel. Is there a way that you can combine the mutual aid and the calls within the city to determine what their 90 percentile would be? Because I think that's apples for apples, as I mentioned last week. When we look at AMR's 90 percentile, it's their whole exclusive operating area.
Yeah.
And we're segregating. So I don't know if you have that slide.
Yeah, I can't. Can you allow me to share again? Okay, and I'm sorry, you want me to show the slide with the exclusive operating area? Is that what?
No, it's looking at Carmel's, I guess it would be their average 90 percentile based on all calls that their ambulance runs to,
Yeah.
regardless of jurisdiction.
So, so this is, so I'm sorry, I don't have, so this was just like something I was planning to, this was just in their jurisdiction. It's not the averages, but it does show that the averages tend to run lower. I did not do an in-depth run of like every single, like go through all 4 of them, but this was just my way of saying, recognizing that, you know, when you do present data and averages, it is lower. And then part of that reason is it's 2 different units of measure. And then also with Carmel, their call volumes can have more of these like variations in their responses, and each month can cause some of these variation 90th percentile, where you kind of see averages tend to remain more stable, if that makes sense. So this is definitely something that I can put together in more detail in everyone and do comparisons between the agencies for sure.
Thank you, Roxanne.
No problem.
Any other questions for Roxanne? Okay, thank you for that report. We will go to item 5 under EMS system performance metrics, and we will welcome back Kimberly Hernandez for communications testing.
Okay, one moment while Stella pulls up the 800 megahertz chart. Okay, we just scroll down just a little bit to show the. Okay, so the 800 megahertz report in November, AMR conducted the drills 90% of the days. Of the days the drills were conducted, CHOMP was at 87% response, ME was at 63, NMC was at 87, and SVMH was at 83. December 18th through January 7th, no 800 megahertz drills were done because AMR dispatch was moved from County Communications to Schilling Place Backup Center, and the 800 megahertz phone was not operable at Schilling Place until January 8th. Of the days the drills could be conducted for December, AMR conducted the drills 100% of the days. Of the days the drill was conducted, CHOMP was at 90% response, ME was at 80, and NMC and SVMH were both at 100%. In January, AMR conducted the drill 88% of the days available. Of the days drills could be conducted in January, CHOMP was at 95% response, ME was at 76, and NMC and SVMH were both at 90. In February, AMR conducted the drills 86% of the days. Of the days the drill was conducted, CHOMP was at 81% response, ME was at 85, and NMC was at 92, and SVMH was at 50. Any questions?
Numbers keep going up. That's good.
Okay, so we'll move on to just an update on the ReadyNet drills. As ReadyNet MCI drills were suspended in spring of 2020 due to the COVID-19 pandemic. And as of March 1st of this year, drills have been resumed.
But we're going to continue to monitor the results of the drills through the quality improvement process during the restart phase and plan to update the committee in May on how we can move forward with using ReadyNet during active MCIs. Any questions on ReadyNet? Okay.
You want to continue?
Yep, okay. So if you can pull up the APOT chart. So for APOT, we've continued to monitor the APOT times to maintain an awareness and to address any delays within the Monterey County EMS system. APOT times increased at Salinas Valley Memorial, Natividad, and Me Memorial from November to December. The most significant increase was a 21% increase at Natividad. Chomp's APOT times stayed stable through the peak with only a 1% increase in December and have remained essentially unchanged since. APOT times decreased at Salinas Valley Memorial, Natividad, and Me Memorial in January. 22% decrease at Salinas Valley, 3% decrease at Natividad, and a 5% decrease at Me. And in February, they also had decreases. Salinas Valley had a 21% decrease. Natividad had a 24% decrease, and Me had a 13% decrease. Any questions on APOT?
Thank you. Thank you. Okay, so we'll move into old business and Ms. Teresa Rios will give us an RFP report.
Thank you.
Our report is brief. As everyone knows, the RFP for a new ambulance provider for Monterey County exclusive operating area closed last Friday, March 5th at 3 p.m. Unfortunately, the county did not receive any bids. At this time, we are assessing our options. Our primary goal is to ensure continuity of services.
Mike Eslander has something to say.
Mike, you have something?
Yeah, is it, I would like to make a comment if I can and just take a couple minutes. You know, I just wanted to communicate to the stakeholders in the group that, you know, as everybody is aware, that we made the decision, a very difficult decision, not to submit a bid on Friday. You know, it's so important that, you know, everybody understands some of the reasoning behind the decision. You know, to let everybody know here is that, you know, nearly our entire leadership team are residents of Monterey County. And, you know, we are part of these communities. And the reason that I just point that out is that you have to know the dedication and the motivation that went behind us trying to attempt to, you know, build a sustainable model around the parameters of the RFP. There was, you know, I can speak personally that there was such a desperation when we realized that, you know, we just could not build a viable model around those parameters. But as you can imagine, I received a lot of phone calls, and there's something really crucial that I wanted to put out there is that, you know, it was a very difficult decision to make, but I also want everybody to know that this is in no way a strategy for AMR to, you know, exit Monterey County. We are committed. We want to continue being your ambulance provider. We would never consider under any circumstance, you know, abandoning the communities here. There should be no concern as to whether or not, you know, Monterey County will be left without a provider. And that's just a really key element for us to communicate to the stakeholders in the whole community. The other thing I wanted everybody to know is that, you know, we are going to continue investing in our employees in the system. You know, this includes moving forward with the largest paramedic scholarship class that we've done to date. You know, on Monday, we have a new program starting with 12 people from Monterey County who will be attending. You know, we plan to update and sort of, you know, kind of keep pace with everything, the great services we've been providing today. We don't plan to reduce unit hours, cut staff, or any of those types of measures. On a final note, I just wanted to put out there that, you know, we have every intent to continue working with the stakeholders. We're committed partners. You know, we have just the utmost respect for all of you that, you know, have continued to steer the EMS system here. You've all made the great, you know, the great commitments of trying to pursue, you know, improvements of the system, and we certainly value that. And I just, you know, I wanted to kind of put out there that, you know, there's so much to be proud of. I think that we do have a great system today. It hasn't been easy. I know there's been a lot of debates that we've, engaged with over the years, but there's a lot to be proud of. And I think that, as we enter the next phase of building the system, I just wanted everybody to know that we stand ready to work together. So thank you for a minute of your time. Appreciate it.
Thank you, Mike. Gary, you have a comment or question?
Yeah, I just, Chair, I wanted to know if it was appropriate if I asked Mike a question.
Sure.
Okay, thank you. So Mike, what I hear you saying, just to paraphrase in my simple ears, is that AMR found the RFP unworkable for your organization. Is that correct?
That is correct. Yeah, we were attempting to build a viable system around those parameters and just were unable to do so.
Okay, so for the EMS agency, Teresa, OES, if you are going to go back and attempt to rework this, we would offer our assistance in any way possible, whether it's just to coordinate the responders to assist you or to be part of that discussion. We would gladly offer that assistance. Thank you.
We appreciate that.
Thank you. Mike Urquidez?
Yeah, thank you, Carla. I just wanted to say to AMR, just thank you. And it really dawned on me, and I think for everybody it's on the EMCC that has worked in healthcare in Monterey County or Harry and OES, is that it really hit home, Mike, when we realized how long you've been here, and Tino and many of your employees, and how by having an unstable RFP in 2 attempts, the emotional roller coaster those families go through, and especially with COVID, for you to be able to hire and retain employees, not knowing if there'll be a company or will they retain their seniority or their pay. I just got to say, thank you. And hopefully you can pass that on to your employees. It really hit home, I think, when that letter came out, that I think us as stakeholders, we've attempted to stop this RFP in the past. We believe it was flawed. And now I think it's been solidified when you don't have any other companies bid, so hopefully that sends a loud message, but more importantly is the emotional roller coaster for you and your employees and your families. And thank you for willing to continue to work with Monterey County and continue to serve if you folks so choose. So thank you.
Thank you.
Just one word, and this is specifically going to go to Mike, but it affects everyone. My first thoughts when I received the word that there were no bidders, and then Mike, your letter struck me very simply that the issue is stability, and much like Chief Recordes indicated, my concerns go out to your people. This has been a very difficult 2 years with two attempts to get a solid bidder with two issues of RFP, and then the COVID and everything else that's going on right now. I deal in stability and try to work within that context, and that's what I hope we can come up with. And that my concerns go out to your people and everyone who has put forth an effort to move this county's ambulance effort forward. Thank you.
Yeah, hi, this is Sharon Henry at AMR, and I'm the COO kind of the Western states for AMR, and I just thank you all so much for your support on this and your understanding. And I just want to echo what Mike said, that we're not abandoning the community. We just couldn't in good conscience put in a proposal that would be unresponsive to this latest RFP or the one prior to it. And I've been doing this 40 years, and I don't know of a time when AMR as an incumbent didn't submit a proposal. So this is not a strategy or a tactic or anything else. This was just out of a need to be transparent and honest, because if we make promises that we can't keep, we'll be a failed company, and this will be a failed system again. So thank you for your patience as we work through this, and we're committed to working through it to the extent the county wants to sit down with us and work out a solution. We're committed to that. So thank you, and we'll get there, I hope.
I hope so too, Sharon. And I think the underlying factor is we've got to avoid the debacle of 2006. We cannot go back to that era, please.
Yeah, that's right. I remember I was around for some of that, and that's exactly why that we're just not going to put something that we can't stand up to, that we have to come back and change later or fail, right? Because those memories are just too clear in my mind and in Mike's mind. So that's why we took this highly unusual step.
Well, the operative word is professionals. That's what we're dealing with. We're dealing with professionals and professionalism. Now let's keep it in that context.
Okay, Jim, last comment from Jim.
Yes, just a quick comment to AMR, telling them that I appreciate their honesty with this. And then a question for Teresa. I don't know if you're prepared to answer this or not, but do you have any idea of the path forward, what we can expect to see both in terms of time and process? That's my question. Thank you.
Yeah, not at this time. Of course, this just happened Friday. We are considering what the options are, and as soon as information is available, we'll share it.
And then just a follow-up, so I'm assuming that everything is still in place to continue operations, and there's contingencies that if extensions need to be made, those are all existing, correct?
We are moving forward, and our primary goal is continuation of services.
Okay, thank you all. We'll move into new business, or I'm sorry, item B for EMCC membership.
Just a quick update. Luz Garcia was introduced earlier as our newest member of the committee. As a citizen representative from South County, and she had an opportunity to tell us about herself. So, welcome her to the committee. And right now we are focused on now starting to fill the remaining alternate positions. We have a couple of leads with the citizen reps to have each to have an alternate. One of the requests from this committee is that we reach out to the hospitality community, and that's one of the leads that we are pursuing. And also to ensure that there's that we add some representation from North County. So those are our goals right now.
And then on to new business.
I got a quick announcement. Monterey County just issued a flash flood watch for river burn scar. So everybody should be aware of that.
Thank you. Yeah. Now on to new business, I'm going to talk about waiver of response time compliance penalties.
Sure. Thank you. In your packet, there was a copy of a memo that we sent out to AMR. The memo is to waive the response time compliance penalties because of the impact the COVID has had on not just AMR, but ambulance providers everywhere. Estela? Okay. So one of the things, in addition to just reporting that the agency issued that letter waiving the penalties for AMR, this committee had requested that for the EMS agency to periodically report on response time compliant penalties. Because, can you go to the next one? Thank you. So here, due to the unique circumstances of the COVID-19 state of emergency, is placing a strain on all pre-hospital care system, and especially contracted providers everywhere. The EMS agency recognizes the impact that COVID-19 has had on AMR, the county's ambulance provider. Section 18.8 of the ambulance service agreement provides for response time exemptions due to declared disasters. And the executive order from March 19, 2020, Governor Newsom declares state of emergency due to COVID-19. So we took action to waive response time penalties under this section. The memorandum was made retroactive to March 19, 2020, and it will remain effective through June 30, 2021. There is an option to extend, supersede, or rescind it at a later time. The next slide provides a report of the 2020 penalties as calculated, but not charged to AMR. Any questions?
Thank you. And we'll move on to the EMS System Quality Improvement Program. Deborah, Hopgood?
Good afternoon, everyone. Our EMS System Quality Improvement Program committees had a pretty extended break due to the issues surrounding COVID, the wildfires, and just other general considerations. Within the last month, we've been able to get those committees back together. So all 4 of the committees, including CQI TAG, TQuick, Stroke, and STEMI, were able to meet. We use those first set of meetings as kind of a reset for our QI program. We asked the people to do some research and thinking beforehand, and then asked them to come to the meetings prepared to talk about the particular organizational capabilities as it relates to our specialty care patients, some of their QA and CQI philosophies, and then some ideas for performance indicators and performance improvement projects for the coming year and on the go forward. As a part of that, we also sent out a SWOT analysis form to our stakeholders and committee participants, asking for their input on the strengths and weaknesses and opportunities and challenges that they see the EMS system as it currently exists and as it faces in the future. So that form, I think, is included in the packet for this meeting as well, and we're asking for responses to come back to us by March 31st. A couple other things that we have in process that have come about as a result of that meetings are we held a policy and protocol meeting for our CQI TAG group to allow them to provide some feedback on the policies and protocols before they went to the MAC group. As Kimberly mentioned, we resumed the daily ReadyNet MCI drills, and then we've been able to obtain at least initial access to Natividad's trauma data and follow-up information so that we can, on the go forward, provide some more information on patient outcomes to our EMS providers out in the field. We have some work to do still on that as far as kind of ongoing access and updates, but that's in process with our IT folks. And then as of this morning, we're also have our initial access to getting set up to access get with the guidelines for Salinas Valley for their CAD and stroke registries. So that'll be huge for those 2 committees to be able to have follow-up for that. And through our conversations so far, we've identified kind of 3 main areas to work on throughout the coming year. The first of those being issues related to ESO, our documentation software, issues with providing more patient outcome data to our providers, and then kind of the whole area of topics surrounding MCIs. So our plan, the drills, training, looking at active shooter harmer policies, and then triage tag days throughout the county as well. So those are all kind of the big things, at least so far, that have stood out. So anything to add, Dr. Burley, or any questions from anyone?
Thank you. Okay, we'll move into announcements for the good of the order. Any member of the committee may make announcements or comments. The EMCC may not discuss or take any action on any item raised during announcements, except to decide whether to place the matter on a subsequent agenda.
This would be the time for OD maps.
Yes. Sam, you want to?
My question and Harry's question was never answered about vaccinated first responders.
Oh, yeah, I neglected to do that up there. So the neither, let me help up there. The short answer is that neither the state nor the county is compiling occupational data in terms of the vaccine databases. The information is there in the sense of that there's been some verification requirements for people getting their vaccines to show some sort of proof of their occupation, but it's simply not entered. I did check with our IT department to see if there's any way to suss that out. And also with the state's, the California Immunization Registry, which at this point is going through a huge remodel, and the whole state is turning to something called My Turn to register for vaccines. So yeah, it's been confirmed right now that information is just simply not available. If occupational data does become something that the state starts tracking, it'll be sort of a moot point because we've gotten past the vast majority of first responders for that. So this has been, yeah, I did spend some time looking into it. Unfortunately, I can say this, that when it comes to the state data, a lot of the capturing of data is a little bit behind the vaccine deployments, and the focus has been on putting needles in people's arms, so to speak, and really prioritizing that. And then the IT dimension is still catching up to the actual vaccine deployment. So unfortunately, that information is just not accessible. So.
It just would be nice to have, so, I mean.
Yeah.
Roughly, we have 85% done, first responders or whatever.
Yeah, I think at this point, anecdotally, what I hear is that there may be, there are some second dose issues, people that have had troubles, first responders, some challenges getting their second doses. But that's a small number, and I believe that everybody that wants to get a vaccine, has got that. One thing I'll add, though, just to that is that for any of the fire chiefs out there, feel free to communicate with me and the agency if you have any of that information, since I know I can't get it from the state. And there may be instances of individuals that did not want to get vaccinated originally, like in December or January, that have changed their mind. And now, fire or EMS personnel that do want to get vaccinated now at this point in the game, if there's any trouble getting prioritized amongst the tens of thousands of people that are eligible now, then I encourage you to get in touch with me, and I'll see if I can assist you. So.
Thank you.
Thank you, Steve.
And then I know we had talked when Dr. Close was on about adding to the next agenda the OD maps. So we could propose that. And I know, Harry, you had mentioned that earlier.
Yes.
Okay. So we can add that to the next agenda. Bless you.
Thank you.
Any other announcements?
Just one aside, I don't want to delay the meeting, we've gone long enough, but I had both my shots at the Pfizer vaccine at CHOMP. They were incredibly well organized and very efficient. I got there a little bit earlier for the second shot, and I was out 4 minutes before my scheduled time. So, the professionals have risen to the challenge, believe me.
Good news.
I think that we want to congratulate you,
Oh,
Carla,
thank you.
on your promotion.
Thank you. Thank you so much. Okay. So our next meeting is scheduled for Wednesday, May 12th at 10:30. And so more information will come. And with that, we could move to adjournment. Thank you all for attending.
Good meeting.
Thank you.